Hello. Hi everybody. My name is Martina Fruhbauerova. I am a clinical psychology doctoral student at the University of Kentucky, and I will be presenting some data we have collected about mental health of suicide attempt survivors during the COVID-19 pandemic. Hoping everybody can see it. Great. So early in the pandemic, there was public apprehension that the COVID-19 pandemic would lead to adverse psychiatric effects such as increased stress, anxiety, other mental health problems, interpersonal violence, and suicide deaths in the general population, as well as among individuals with pre-existing mental illness. And indeed, a review of recent studies during the first year of the pandemic found that anxiety, depression, and distress increased in the early months of the pandemic. However, despite these widespread concerns, suicide rates, life satisfaction, and loneliness remained largely stable throughout the first year of the pandemic. In fact, reports show that suicide deaths increased in 2020, and for the first time in over a decade, suicide was not the first in the top 10 causes of death in the United States in 2020. Also, importantly, non-COVID-19 hospitalizations dropped below typical levels, in part due to the overburdened units and restrictions of numbers due to distancing with COVID-19 patients. Although suicide death rates did not increase in 2020, crisis and suicide hotline usage did increase. Emergency departments, visits for suicidal ideation, and attempt also made up a larger percentage of visits than in comparable time periods the previous year. So it is possible that help seeking and the use of crisis services might have protected individuals from dying by suicide. Alternatively, a recent qualitative study on individuals with suicide ideation found that for some people, the pandemic created barriers to carrying out their suicide plans, such as the inability to obtain lethal means. However, some of these nuances have not yet been examined, namely by directly asking people with lived experience of suicide about their experiences. So there is a reason to believe that for some people, the experience with isolation and mental health challenges prior to pandemic might lead to more resilience in the face of COVID-19, and for people who had not had these experiences. And it is still not clear whether suicide attempt survivors perceive themselves as being more resilient during the pandemic and how the pandemic affected them and their coping. Thus, using a mixed method approach, the current study sought to examine the impact of the pandemic on individuals with lived experience of suicide attempt compared to those without this experience, and whether they felt resilient during the pandemic and whether there were any differences in the utilization of mental health resources between these two groups. And given the novel nature of the pandemic and its impact on mental health, including the lack of literature in this area, we did not form any a priori hypotheses. This study utilized an online crowdsourcing platform for research linked to Oxford Medical or Enter. Study data was collected between May 26, 2020 and June 25th. Participants received $1.50 survey. My co-presenters. A subset of participants who endorsed history of suicide attempts were also eligible for follow-up questions, for which they received additional $3.25, and the entire survey took approximately 25 minutes to complete. Our data set included 1,351 adults from 15 different states. Inclusion criteria for participation included being a U.S. resident, at least 18 years of age, and at least 90% approval rating as an MTurk worker, and completion of at least 500 previously approved MTurk tasks to ensure high data quality. This study investigated suicide attempt survivors' perception of their resiliency and the effects of the COVID-19 pandemic on those with and without a history of suicide attempts. Pandemic effects were defined using 4 indicators, such as the visits to a mental health professional that could have been therapist or psychiatrist, and via telehealth or in person. then psychiatric hospitalization, contact with hotlines, and by set of variables, which we refer to as pandemic impact. And these variables, the pandemic impact variables, included scales of depressive symptoms, overall impact of COVID-19 on functioning, optimism in light of the pandemic, feelings of despair due to the pandemic, and impairment due to the pandemic. So as for our results, approximately 12% of our entire sample, which was 159 participants, reported having made at least one suicide attempt with the intent to die. As reported in this table 1, a greater percentage of participants with history of suicide attempts self-identified as cisgender women, non-binary, gender non-conforming, or bisexual or pansexual, as compared to those without history of suicide attempts. And fewer participants with history of suicide attempts reported ever being married. Detailed information considering participants' visit to a mental health professional, either via telehealth or in person, psychiatric hospitalizations, contact to hotlines, and pandemic impact since March 2020 are reported in Table 2. During the pandemic, almost 1/3 of participants reported having visited a mental health professional, with 2.3% of these participants reported having sought psychiatric hospitalization. Nearly 10% of the participants reported having contacted some type of hotline. And additionally, individuals with history of suicide attempts also reported higher mean scores across all pandemic impact variables, except for the optimism about overcoming pandemic variable, which just suggests less optimism. In this table 3, we can see the results from the hurdle model, in which we tested association between presence or absence of history of suicide attempts and frequency of mental health professional visits, psychiatric hospitalizations, and contacts to crisis hotlines. In each model, we controlled for age and gender. So participants with history of suicide attempts were more than three times likely to visit a mental health professional during the COVID-19 pandemic as compared to those with no history of suicide attempts. And history of suicide attempts also predicted greater counts of visits to a mental health professional. This indicated that they were 66% increase in the number of mental health professional visits for those with history of suicide attempts. Participants with a history of suicide attempts were 7 times more likely to have been hospitalized for psychiatric reasons and 3.5 times more likely to have contacted any type of hotline during the COVID-19 pandemic. However, history of suicide attempts did not predict greater counts of days being hospitalized, nor greater counts of those crisis hotline contacts. In the table 4, we can see the results from the hierarchical multiple regression, which helped us determine whether history of suicide attempts predicted the set of variables we call pandemic impact variables. So again, age and gender were entered at step 1 for each model as control variables, accounting for between 2.3% and 7.6% of the variance. And history of suicide attempts was entered in step 2 and significantly predicted negative, that is worse, outcomes in pandemic impact variables, explaining between 1% and 4% of unique variance in each model. Several themes emerged from the qualitative data as well. Some participants wrote about how they felt optimistic and found a silver lining in light of the pandemic. In one participant's words, it made me realize that while things may seem bad and things may be really bad at a time, things can and will get better. It's made me more optimistic. I think it's hardened me a little bit, but in a good way. I may get figuratively knocked down, but I'll keep getting back up. And I think the other thing it changed was accepting and acknowledging when I'm struggling with a problem or emotion, etc. It's made me more self-aware, which has then in turn allowed me to experience more things in life. However, for others, the pandemic seemed to make their outlook on life worse. This sentiment was expressed as one participant wrote, "When you get over that much pain, I think it could make you stronger. One thing that has happened is that I am now investigating my thoughts, feelings, and actions. I'm also in therapy and back on my medication. I don't ever want to get that bad again. So this time I'm doing everything I can to get better." Also, overall, almost 58% of individuals who endorse history of suicide attempts reported that they believe that having survived a suicide attempt definitely or probably made them more resilient. On the other hand, almost 22% weren't sure, and almost 21% reported probably not or definitely not being more resilient. So what are we taking away from this? Our results revealed that significant differences between participants with and without a history of suicide attempts are present. Since the start of the COVID-19 pandemic in March 2020, participants with history of suicide attempts were more likely to seek services from mental health professionals and crisis hotlines than those without a history of suicide attempts. However, rather than more problems, this could suggest a possible increased willingness and comfort to seek professional and social support, as well as better coping skills learned through previous mental health contacts, as we have also learned from some of our qualitative responses. Participants with a history of suicide attempts were also 7 times more likely to have been hospitalized for psychiatric reasons. However, only about 9% of suicide attempt survivors were hospitalized. As such, these findings should not be interpreted as an indication of worse functioning. In fact, merely reporting a history of suicide attempt is often related to future hospitalization, as it has been seen as a marker of risk in many assessment tools. In this case, it is perhaps another indicator of increased willingness to seek help, especially in emergency situations. This study also examined variables related to individual scope during the pandemic, including the impact on depressive symptoms, daily functioning, despair, impairment, and optimism about overcoming the pandemic. Although history of suicide attempts predicted higher distress during the COVID-19 pandemic, it explained only 4% at most of unique variants. In other words, individuals' histories of suicide attempts did predict more negative impact of the pandemic on these individuals, but it indicated low explanatory power, and while statistically significant, this result may not be clinically meaningful. It is likely that because the pandemic crisis posed additional distress on most people overall, regardless of their histories of suicide attempts, there may be a better predictor of pandemic impact than history of suicide. And indeed, in the face of the pandemic, almost 60% of suicide attempt survivors reported that having survived a suicide attempt had made them more resilient during the pandemic. Thus, as previously discussed, certain individuals who lived through a suicide attempt might have been better equipped and readily available to seek help and endure additional distress during the pandemic. This study, of course, is not without its limitations. So the nature of convenient sampling method means that the present results cannot be generalized to the wider population. The online recruitment strategy through MTurk and Cloud Research approved list may have also increased the self-selection bias and made it more difficult for individuals with limited technology access to participate. And only 12% of the sample consisted of participants with history of suicide attempts, so it is difficult to make any inferences about this population. The data also relied solely on self-report with no behavioral measures or standard measures of mental health symptoms. And furthermore, the pandemic impacted people differently based on state of residence, as some states had different levels of restriction on daily living. So lastly, I'd like to sincerely thank my collaborators, especially Dr. Julie Sorrell, who's been an amazing mentor to me. And I'd also like to thank you all for your attention and the organizers for putting such an amazing conference together. That will be all for me. Thank you.
Thank you for pushing my presentation live. Hi, everyone. My name is Eva Trinh, and I am a health scientist on the Centers for Disease Control and Suicide Prevention team. Today, I'm joined by some of my co-authors, Ellen Yard, Asha Ivy Stevenson, Jing Wang, Lakshmi Radhakrishnan, and Deb Stone. It's good to be with you today to share our work monitoring suspected suicide attempts in emergency departments in the United States. Today, I will be presenting data from 2019 to 2021. So suicide is a public health problem. Between 2000 and 2020, suicide rates increased by 30% in the United States, with slight declines noted in 2019 and 2020. The COVID-19 pandemic impacted risk for suicide. Specifically, there were reports of elevated adverse mental health conditions among young adults, racial ethnic minorities, essential workers, and unpaid caregivers. These groups reported struggling with mental health, substance use, and suicidal ideation during June 2020. There was a greater prevalence of mental health symptoms among public health workers, especially those who were unable to take time off or worked more than 40 hours a week. There were also increased experiences of poor mental health and increased suspected suicide attempts among adolescents and young adults, especially among adolescents who did not feel close to persons at school or virtually connected to family, friends, or other groups. Although this background is largely focused on mental health, it is important to note that mental health is one risk factor for suicide. Persons who do not experience mental health illness or symptoms can also be at risk for suicide. Last year, my colleague Ellen Yard published the surveillance of suspected suicide attempts in emergency department visits, or ED visits as I'll refer to them, for adolescents aged 12 to 17 years and young adults aged 18 to 25 years. For adolescents, the number of weekly visits for suspected suicide attempts decreased during March and April of 2020 when compared to 2019, which was during the beginning of the COVID-19 pandemic. However, by May of 2020, there was an increase in ED visits for suspected suicide attempts, which was more pronounced among girls. Specifically compared to the same time period in 2019, during July to August of 2020, mean weekly number of ED visits was 26% higher among girls. In the next year, compared to 2019, during February to March of 2021, mean weekly number of ED visits was 50.6% higher among girls and 3.7% higher among boys. For men and women aged 18 to 25 years, a decrease was also observed during spring 2020 when compared to the same time period in 2019 by a 17% decrease. However, similar to the adolescents, a subsequent increase was observed throughout the beginning of the pandemic. Compared to the same time period in 2019, the rate of ED visits for suspected suicide attempts were 1.6 times higher during March to April of 2020, 1.1 times higher during July to August of 2020, and 1.3 times higher during February to March of 2020. Suicide prevention requires a comprehensive public health approach that begins with the use of data to drive decision-making and prevention efforts. Syndromic surveillance is one such data source to aid in these efforts. Near real-time syndromic surveillance of ED visits allows for the rapid detection and response of emerging public health threats. Early concerns of the potential impact of the COVID-19 pandemic on suicidal ideation and self-harm demonstrated the need for such timely data. The Centers for Disease Control and Prevention monitors near real-time data of suicide and suicide-related outcomes presenting to EDs using the National Syndromic Surveillance Program, also referred to as NSSP. Our objective is to describe trends in suspected suicide attempt visits to emergency departments before and during the COVID-19 pandemic to inform suicide prevention. We are extending the work that was previously shared from Ellen and colleagues to include all age groups and a longer time period. CDC receives near real-time data from the NSSP BioSense platform to monitor and assess suicide-related outcomes. Among all visits received by NSSP from 50 states and the District of Columbia, NSSP receives data from about 71% of emergency departments nationwide, with regional differences in facilities contributing data. 75% of ED visits are reported within 24 hours of the clinical encounter. To query data in NSSP, we use the suicide attempt syndrome definition developed by CDC in partnership with state and local health departments. The definition incorporates ICD-9 and ICD-10-CM discharge diagnosis codes, SNOMED billing codes, and free text indicating the reason for the patient's visit was for a suicide attempt. The definition also has exclusion terms if the visit was not of a suicidal nature. The definition applies the inclusion and exclusion criteria to two fields in the data system, the CC and DD category, which means the chief complaint and discharge diagnosis category fields. We analyze weekly trends of suicide attempts in emergency department visits using Excel. The visits spanned from January 1st, 2019 to December 31st, 2021, before and during the COVID-19 pandemic. We also stratified the data by sex and age group using the existing variables in the NSSP BioSense platform, which includes set age groups from 5 to 11, 12 to 17, 18 to 25, 26 to 34, 35 to 44, 45 to 54, 55 to 64, and then 65 plus. This graph shows the trends for weekly rates for 2019, 2020, and 2021. The green line shows the weekly rates for suspected suicide attempts per 100,000 emergency department visits for 2019. This serves as our reference period when comparing trends and rates in 2020 and 2021. There are also icons marking significant COVID-19 events in the United States. The arrow on the purple line marks when a national emergency was declared and states started issuing stay-at-home orders. The needle at the end marks when the first vaccines became available. Suspected suicide attempt rates increased soon after the beginning of the COVID-19 pandemic and remained elevated throughout 2020 and into 2021. On the graph, you can see the increase in the purple line for 2020 soon after the US declared the pandemic as a national emergency during March, which is marked as week 10. Comparing this purple line for 2020 with the green line for 2019, you can also see how the rates remain elevated throughout the year. The blue line for 2021 shows the continued elevated rates in early 2021. Then rates began declining around week 10, which is March, until August, which is marked as beginning on week 32. Then you see a fluctuation for the rest of 2021, with rates bouncing back and forth between rates observed in 2019 and 2020. Overall, the annual rate of weekly suspected suicide attempt visits were higher in 2020 and 2021 compared to 2019. Specifically with 240 suspected suicide attempt visits per 100,000 ED visits in 2019, 295 per 100,000 in 2020, and 287 per 100,000 in 2021. This table breaks down the emergency department visits rates for suspected suicide attempts per 100,000 visits. The information is stratified by sex and age group. Females aged 12 to 17 years had the highest ED visit rates for suicide attempts, highlighted in the blue cells, compared to all age groups, which is also reflective of previous findings on suspected suicide attempt visits and increases in ED visits among this group for mental health concerns during the pandemic. The next highest visit rates for suicide attempts are seen in young adult males and females aged 18 to 25 years, highlighted in green. Also of note are the rates for the 35 to 44 years age group, highlighted in yellow. Although not as high as adolescents and young adults, this age group also experiences higher than usual rates. This table breaks down the mean number of weekly ED visits for suspected suicide attempts and the percent change of visits compared to 2019. The largest percent increases in suspected suicide attempt visits were observed for females aged 5 to 17 years in 2021 when compared to visits in 2019 and 2020. These are highlighted in blue and green. Highlighted in yellow are other percent increases that were also very high, include females aged 12 to 17 in 2020 compared to 2019, males and females aged 12 to 25 in 2021 compared to 2020, and males and females aged 65 plus in 2021 compared to 2020. There are several limitations when using syndromic surveillance data that would be important to mention. First, ED visits noted a precipitous drop in March to April 2020. The sharp decline in all ED visits during the pandemic likely affected the number and proportion of visits for suspected suicide attempts. This data is also from a convenience sample that represents approximately 71% of all emergency departments in the US. The syndrome definition queries from chief complaint terms and diagnostic codes that varies by jurisdiction, vendor, and hospital systems. It does include exclusion terms for non-suicidal self-harm. However, the query doesn't exclude all visits for non-suicidal self-harm. Also, differences in availability, coding practices, and reporting of chief complaints and discharge diagnoses from facilities might influence results returned by the syndrome definition. And follow-up visits for the same event was not possible, so the number of ED visits for suspected suicide attempts might be lower than presented. These data also likely underrepresent the true prevalence of suspected suicide attempts because persons with less severe injuries might be less likely to seek emergency care during the pandemic when many persons avoided medical settings to reduce the risk for contracting COVID-19. Another caveat is the difficulty of determining intent in younger children and their understanding of the consequences of suicide before age 10. Finally, this analysis was not designed to determine whether a causal link existed between these trends and the COVID-19 pandemic. Overall, ED visits for suspected suicide attempts increased at the beginning of the COVID-19 pandemic and fluctuated in 2021. The group most impacted were children and adolescents aged 5 to 17. Syndromic surveillance is useful for detecting changes in suspected suicide attempt rates in near real time. Upticks in suspected suicide attempts can be communicated to public health professionals to inform prevention. A comprehensive public health approach to suicide prevention is needed to address the many factors associated with suicide and suicide attempts. This approach can help mitigate the impact of pandemics and other disasters on suicide and suicide attempts. More specifically, syndrome surveillance allows us to promptly detect changes in suicide attempt rates and provide an opportunity for public health response, especially during times of infrastructure changes, such as during the beginning of the COVID-19 pandemic. As concerns were raised for suicide risk in the population, and especially youth at the beginning of the pandemic, syndromic surveillance allows for the monitoring of these risks in emergency department settings and a community response to emergent trends. This is a list of references I presented, and thank you for joining my presentation today.
So, thank you very much for the interesting talks, and hello everybody. Thank you for joining and welcome to my presentation about the early impact of the COVID-19 pandemic on suicidality and psychiatric hospital admissions. To introduce myself, my name is Christoph Hörmann and I am PhD student in Sebastian Olbrich's research group Electrophysiology and Prediction at the University Hospital of Psychiatry in Zurich. Since first infections were reported in 2019, coronavirus disease has spread into almost every country on the planet, and social distancing, movement restrictions, and lockdowns affected almost every aspect of our lives. After the spreading of the virus and containment measures went on, mental health researchers have expressed concern that the pandemic could harm public health and exacerbate suicide risk. In fact, a growing body of research reported a sharp increase in the prevalence of severe mental distress, depression, anxiety, post-traumatic stress, and insomnia for the general population, and similar effects, but with an even higher prevalence, were found among healthcare professionals. Individuals with pre-existing disorders, especially when undertreated, might lack the resilience, coping strategies, and support, and seem to be at risk for developing severe mental health problems. Following the last global pandemic, which was Spanish flu in 1918, elevated suicide risks were observed. And also after 2003 severe acute respiratory syndromes outbreak in Hong Kong, rising suicide deaths, as well as higher prevalence of anxiety, social isolation, and psychological distress were reported, especially for people aged 65 and over. Social isolation and lack of social exchange are well-known risk factors for suicidality. Unemployment is another important risk factor and associated with a 2 to 3 times higher relative risk to die by suicide. Although several mental health indicators have been examined, there is not very much empirical research about the impact of the COVID-19 pandemic on suicidality. A study from UK by Chen and colleagues had analyzed referrals and self-presentations to mental health care services and found substantial drop of patients during the first wave. A meta-analysis by Perkins and colleagues reviewed suicide data from 21, especially high or upper middle-income countries since the pandemic's offset until the mid of 2020, and found no evidence of an increase in suicide rates in any of them. In 12 areas, they even noted significantly decreased suicide rates. The Swiss Corona Stress Study found that calls to the Swiss helpline Die Dargebot mehr Hand in connection with addiction or suicidality had increased during the first lockdown, which could be a possible indicator of increasing suicidality in Switzerland. In an international comparison, Switzerland has an above average suicide rate, which is 11.2 per 100,000, what lies in the upper middle field. In Switzerland, suicide is the second leading cause of death among the 14 to 40 years old, and every day 2 to 3 people die from suicide, where cases of assisted suicide are not included. After the suicide rate in Switzerland had been steadily falling for decades, no further decline has been recorded within recent years, despite several cantonal and federal suicide prevention programs. Here you see the last available official cause of death statistic, which includes suicides only until 2018. To mention here is that during the last decade, assisted suicides have more than tripled up. Additionally to actual suicides, there are 33,000 estimated suicide attempts in Switzerland every year, as well as another 500,000 people who experience suicidal thoughts, making up 8% of the population. So the aim of the study presented here was to investigate the early impact of the COVID-19 pandemic on suicidality and the concurrent demand for inpatient health care. Therefore, we compared admissions to the inpatient wards of the University Hospital of Psychiatry Zurich for suicidal patients during the early COVID-19 aftermath with control data from 2019. Data was collected for the 6 months starting the day after the first COVID-19 case was confirmed in Switzerland, which was the 26th of February. Contrasting a priori expectations, our initial hypothesis of finding a greater number of suicidality-related admissions during COVID-19 could not be confirmed. After noticing that during the early phase of the pandemic, even fewer patients with suicidal thoughts or suicide attempts were admitted to our clinic, we wanted to examine the significance of this decline and estimated the pandemic's impact on the number of admitted suicidal patients. Therefore, we used an interrupted time series design with a segmented regression model, for which we defined an event predictor variable from calendar week 11 to 19, 2020. In the table, you see a comparison of the 2020 admissions with control data from 2019. As told before, instead of rising admissions, we found 9.14% less total admissions, and also that fewer suicidal patients were admitted during the early phase of the pandemic. In particular, we found that suicidal admissions had decreased significantly in the 6 months following the COVID-19 outbreak. We also saw that patients were more often involuntarily admitted and had fewer previous admissions than in the 2019 control period. Maybe one of our most important findings is that the share of first-time suicide attempters had more than tripled during the first pandemic wave in Switzerland. To analyze the early impact of the COVID-19 pandemic on suicidality-related admissions, we conducted separate regression analyses for patients with suicidal ideation and patients admitted after attempting suicide. In the upper chart of the figure, you see the weekly admissions of patients with suicidal ideation for whom our model was able to explain 36% of variance and indicated a significant step change of 38% between calendar week 11 and 19, which refers to the first Swiss lockdown period. In the lower part, you see the hospitalizations of patients after a recent suicide attempt, for which our model had no predictive value. Although during the first lockdown phase, only half as many attempters were admitted as in 2019. You can also see that there was no sudden rise following the loosening of measures after week 20. Although expected otherwise, we noticed that admissions to our hospital had declined in the first 6 months with COVID-19. And instead of finding more suicidal patients, we found that significantly fewer patients with suicidal ideation had been admitted during this early phase of the pandemic. Interestingly, also the cantonal police had noticed a comparable decline in actual and attempted suicides for the year 2020. Limitations of our study are that only data of a single but large psychiatric hospital were used. Also, the generalizability of our results is limited by the underrepresentation of older adults and minors, as specialized wards were not included. What are the implications of these findings? First of all, the presented results must not be interpreted as a more clear signal against an increase of suicidality. The higher share of compulsory admissions, as well as a 3 times higher rate of admitted suicide first attempters in the immediate aftermath of COVID-19, could also mean that fears of contagion had reduced the readiness for treatment and that suicidal patients did not present for mental health care. In addition, the pandemic and containment measures may have changed risk mechanisms or groups at risk. For example, pandemic measures such as distance regulations or contact bans may have increased social isolation, specifically for those individuals with few social contacts in private life, but maybe who have a functional social network at their workplace. Interestingly, while suicides tend to increase after wars and economic crisis, suicide rates have repeatedly declined during wars, which is explained by greater social cohesion against a common foe. Eventually, a similar mechanism might have impeded suicide death so far. And how about the further trends? Our study analyzed data only for an early phase of the pandemic, and you might wonder about suicide rates and suicidality in later stages of the pandemic. Despite not noticeable economic effects, most studies and meta-analyses so far suggest that the distress experienced has not yet led to an increase in suicide death. Many studies even report a modest reduction in suicide rates, while most of the others do not report a significant increase for the first year of the pandemic. But there is some evidence for higher prevalence of suicidal ideation since the outbreak of COVID-19. And last but not least, children, adolescents, and young adults seem to be particularly affected by the pandemic and the measures taken. To conclude, the long-term impact of the COVID-19 pandemic and suicidality may not have unfolded yet, and we might be better off expecting it in the upcoming months or years. So thanks for your attention, and thanks goes also to my research team and my supervisor, and great thanks also to the organizing team and everybody contributing and making this symposium possible. So questions in the chat? I don't see any. If there are no questions, here you can see the link to the published paper of our study. There you will find all the references cited. The others for the newer data is shown here. So thank you very much for your attention.
Hello, everyone. I am Vibha Neupane, and I'm from Nepal. I'm currently working as a research officer in TPO Nepal. Let me quickly share my screen for the presentation. Okay. TPO Nepal, the organization I am working for, has been working in the field of mental health since last 17 years. And during the COVID-19 pandemic, we carried out research on the assessment of suicide and self-harm in this crisis situation. So getting into the presentation, as we all are aware about the coronavirus disease 2019, which is a contagious respiratory disease. The current situation in Nepal, as you can see in the shared screen, we have a total cases of more than 9 lakh, and out of which the recovered cases are 9,67,262, and the total number of deaths due to COVID-19 is 11,952. Many studies have demonstrated an increased psychological distress and adverse impact on mental health and psychological well-being of people following any kind of disease outbreak or any other emergency situation in the past or in the present. So TPO also conducted a social media survey after a month of nationwide lockdown following COVID-19, which showed the result showed a higher prevalence of psychological distress among Nepalese population. So now this study, assessment of suicide and self-harm during COVID-19 pandemic in Nepal, was conducted to explore the status of suicide and self-harm during COVID-19 pandemic in Nepal. This study used a mixed method which included both qualitative and quantitative approach. We used the secondary data from Nepal Police to analyze the trend of suicide from last 5 fiscal years. And we also used a qualitative method which included the key informant interview with psychiatrists, psychologists, psychosocial counselors, and media reporters as well. We actually did a purposive sampling, and the sample represented the all 7 provinces from Nepal. All except 2 KIIs were done remotely, considering the pandemic and lockdown situation of Nepal.
V, I'm sorry, your slides aren't advancing.
Sorry. Can you see my slide now?
Yes, we see the slide up as well as the other slides on the left panel.
So you can see the result, the slide shown the result currently.
Yes.
Yeah. Okay. So I was okay. So let's continue. So as we can see here, based on the suicide data of last 5 fiscal years, the percentage of suicide is in increasing trend till the fiscal year 2076 and 2077. From the data shown in this figure, it can be said that the annual growth rate of suicide is almost the same like the previous years, despite the growth rate of suicide that has been increasing every year since fiscal year 2072-73. But if we look at the segregated data in the other slide of last 4 months, that is from Chaitra to Asar of past 4 fiscal years, the data shows that the growth rate of suicide in fiscal year 2076-2077 has been increased a bit more when we compare to the fiscal years 2075 and 76. So this is actually the facts and figures of suicide in Nepal that we got from the police record. And from the qualitative interviews, we explored the detailed descriptive response from the mentioned stakeholders about their experiences and perspective on suicide and self-harm during this status of pandemic. And also we explored the factors that are associated with the increase in suicidal behaviors. The qualitative findings suggested that the mental health and psychosocial problems has been increased following the COVID-19 pandemic, such as stress, frustration, sadness, hopelessness, and loneliness has been increased among people in this situation. And the most commonly reported problems were anxiety, depression, and fear. Similarly, mental health problems such as a substance use disorder, bipolar disorder, psychosis, and psychosis has also been increased, has also been severe in people who were already on the medication. These are some quotes that we have kept here from the respondent from our qualitative interviews. Majority of the respondents reported that the increment in the completed suicide cases has not actually significantly increased and is actually in the normal trend. However, almost all of them shared an increase in suicidal behaviors in the community as well as health facilities. So there are many factors contributing to the increase in suicidal behaviors among people in this emergency situation. So we can see the listed out factors in the screen, such as financial hardship and unemployment, uncertainty of COVID-19 pandemic and its multidimensional impacts, increased incidence of domestic violence during the lockdown after the COVID-19 pandemic, increasing stigma associated with COVID-19 and COVID-19 infection and contagion, limited access to general and mental health services and social security, and fear of getting infected and fear of losing the loved ones due to COVID-19. And again, these are some of the quotes that I have mentioned here that was stated by our respondents from different provinces during our qualitative interview. We also explored some of the ideas about the available resources and services from our stakeholders, where they reported that there is lack of services in the community level to the people in need. There is also limited mental health services, specialized mental health services, and it is limited to a few hospitals in city areas only. Also, they reported that psychosocial counseling and basic mental health services offered by non-government agencies is limited. Is only available in the limited region and for limited duration. The data of this assessment were actually collected from a relatively small sample using qualitative research method, which of course cannot be generalized over the entire country in general. So some of the recommendation that was formulated based on the findings of this assessment of this study were to conduct mass awareness raising campaigns addressing COVID-19 related myths and misinformation, to ensure designated support to at-risk population immediately, to ensure mental health and psychosocial services are available to the community people, to mobilize existing community level health protection and education system, to strengthen multi-sectoral coordination and collaboration in each tier of the government, to ensure a systematic database system to record and report suicide and suicidal behaviors, and also to generate evidence on suicidality in wider context and conduct advocacy for suicide prevention. So these are the references that we have used. And this is all for my presentation. Thank you. Any questions?
Looks like we got no questions and we get good on time. Right, if there are no questions, I think we can just close out. Thank you all.
Thank you all. Thank you, Martina. And
thank you. Thank you, everyone.
Symposium. Goodbye.
Thank you. Goodbye.
Goodbye.
Goodbye.